I think that's one of the challenges in medicine is there's a reason that MD or DO comes after your name. It doesn't become your name. And it's really easy to get burnt out when your identity and everything that you are is wrapped up in your job.
Hello there.
Hello, my apologies. I received about 4 different Zoom links and I was just going through each one of them and giving them a couple minutes. So my apologies.
That's okay. I was doing the same thing. This is the first time on the new setup that we have for e-shadowing. So we got to grow together. Thank you for allowing us to do that.
Not a problem.
Welcome. Thank you so much for joining us. I'm excited to talk about some addiction medicine today, some toxicology stuff as well. Let's chat about what exactly that is, because I think a lot of people, when they think about going to medicine, going to be a physician, addiction medicine and toxicology aren't things that people think about. They think of like, ooh, surgery, emergency medicine, family medicine, internal medicine. But there are these little niches, which is why I love e-shadowing, why I love an older podcast that I did called Specialty Stories, where I get to really hone in on these specialties that are kind of diamonds in the rough. So what is this specialty of yours?
Yeah, absolutely. So I'm super glad that you're doing this. Certainly when I started medical school, this was not even something that was on my radar. And so it's great to be able to talk a little bit about it and to talk about kind of my path and how I ended up where I am. Toxicology, the big broad definition is the study of xenobiotics and what they do to the body. And so a xenobiotic is anything that's in the body that finds its way into the body that's not supposed to be there. And that includes drugs of abuse, prescription medicines, pharmaceuticals, envenomations, all the wonderful chemicals that, make our lives better the vast majority of the time, but sometimes can cause problems. And then addiction medicine is a very new specialty that recognizes that when people start using substances, sometimes those substances can become all encompassing and all consuming. And what are we going to do about that? And how are we going to resolve that? And there's a lot of ways to do that and a lot of options that go along with that.
How did you find this world?
So actually, I did an emergency medicine residency and at UC Davis in Sacramento. And while I was there, one of the required rotations was toxicology. I spent a month on that service and was involved with the Poison Control Center and really enjoyed it a lot. I had a commitment to the US government, the US Navy. And so it was kind of put on the back burner for a few years while I did that. I was stationed at Naval Medical Center San Diego, and many of my mentors, a lot of the people that I worked there were toxicologists, and we started talking. And when it was time to leave the Navy, they said, "Hey, why don't you do this?" And my dear wife supported that decision, and we did a tox fellowship together, 2 years. And then I've been doing that since 2011. And then probably about 5 years ago, addiction medicine came kind of onto the forefront, and they had a pathway for people that were in the field and doing it. And I went ahead and pursued that because a lot of what I do as a toxicologist involves drugs of abuse and people who get in trouble with those drugs of abuse. So it's kind of been an evolution of, oh, I didn't even know about this, and I'm now exposed to it, and I really like this, and let's explore this some more and see where it goes. And then that led to something new and different. And I think that's the beauty of medicine is there's a lot of different directions that it can go. I think the goal or the key is not to get pigeonholed or find yourself doing something that you continue to do only because you've always done it, not be afraid to explore new things.
Yeah. Is being a toxicologist slash addiction medicine physician, is that a full-time specialty, or is it on top of or adjacent to being an emergency medicine physician?
So for me, it's adjacent to, but there are full-time toxicologists and addiction medicine physicians that are out there. I chose for my practice to kind of be an amalgam of all of the above. I work about 100 hours a month in the emergency department at UC San Francisco as part of the emergency medicine residency there. And then along with two partners, we share call every month, about roughly 10 to 12 days out of the month. I carry a pager and answer calls related to toxicology and addiction medicine. And a lot of the addiction medicine involves both the acute treatment of intoxicated states, withdrawal states, and then getting people plugged into various resources in the community. With that being said, toxicology is such a broad field that I have people that I know that work full-time in industry, for drug companies, making sure that they're meeting all of the regulations and keeping drugs safe. I know full-time addiction medicine physicians whose all they see day in and day out are patients that have substance use disorders and are getting treatment for that. And treatment for that can mean a lot of different things.
Yeah. Very interesting. What is bread and butter addiction medicine?
So bread and butter addiction medicine currently in the United States is opioid use disorder. There is a huge problem with opioids and people becoming addicted or developing substance use disorders. Addicted is kind of an older term that some view somewhat pejoratively, like it's not a preferred term. So substance use disorder is the preferred term. And there are a lot of different methodologies to treat that. Currently, the favored one is medications for opioid use disorder. These are things like buprenorphine or naloxone, medications that can be administered to help with cravings, as well as the physiologic changes that take place when someone has been using opioids for a very long time and then stops using them. And so for me, my bread and butter addiction medicine is seeing people in the emergency department after an overdose, getting them through their overdose, and then offering them these various options, including medications for opioid use disorder.
Yeah, very interesting. I know we were chatting about a very interesting case you had. Is that something we can go through?
Absolutely. So one of the things that I love about toxicology and really got me interested in it was physiology. And in medical school, the first 2 years, as you know, you're learning a bunch of stuff totally out of context. It's kind of an exercise in memorization and spitting stuff back, but without any real context for it. And for me, tox puts all of that to use because it's all physiology and it's all understanding these various pathways. And one of the things that I remember as an undergraduate in chemistry and biochemistry was the Henderson-Hasselbalch equation, which talks about pH and acids and bases. And at the time, I thought, I don't get this. I don't understand this. Why am I learning? Well, I had a case a number of years ago that kind of put it all into perspective. And I'm going to kind of present it as an unknown and we'll kind of work through it. It was a 65-year-old woman who had a history of rheumatoid arthritis who came to the emergency department complaining of pain, and it was in particular in her ankle. And that was the site of her rheumatoid arthritis. She was seen, she was evaluated, she was kind of triaged to a different area of the emergency department while a bed became available in the area that she was delineated for. She had a seizure. And it was a pretty significant seizure. It was a full-on, the full herky-jerky's loss of consciousness. And when she came to, the focus suddenly shifted from her pain to why is this lady having a seizure? She had some laboratory studies that were drawn that were abnormal, but not really all that significant. And then through the course of her ED evaluation, it was determined that she needed to be admitted for workup of this seizure and why is this 65-year-old woman who's never had a seizure before having seizures now. And I got involved kind of later in her case after she'd been admitted to the hospital. And the admitting internal medicine resident called me and said, Dr. Durock, I'm really sorry to bother you, but something is not adding up here. There's something off. And it turns out that her acid base status was all screwy. A blood gas was drawn that didn't make any sense. And people had inadvertently attributed all of those things to her seizure. She had both a metabolic acidosis and a respiratory alkalosis. She was breathing too fast and she had too much acid in her blood. And when he called me, I heard the story, I heard the history and said, send this one test and I'll follow along and I will call you or you call me when it results. And that test was a salicylic acid or aspirin assay. And it came back at 80, which is markedly elevated. It's much more elevated than anticipated from someone taking it therapeutically. And the reason for her seizure had everything to do with the fact that she was poisoned by aspirin. And the reason that I bring up the Henderson-Hasselbalch equation is one of the therapies that we use is sodium bicarbonate. So we administer sodium bicarbonate, basically baking soda, through the IV into patients in the treatment of aspirin poisoning. She ended up also getting dialyzed, but that took some time to arrange, and the dialysis was to get the aspirin out. And the whole reason that we give the sodium bicarbonate has everything to do with that darn Henderson-Hasselbalch equation that's the bane of every undergraduate taking chemistry and biochemistry. The sodium bicarbonate changes the pH of the blood and traps the aspirin in the blood and prevents it from getting out into the organs where it can cause toxicity. And it buys us time either for the kidneys to get rid of it or to set up dialysis to get it off. So she had one session of dialysis and was discharged the next day. But had I not been there and had that resident not identified that something was off, that woman would have potentially died because she was starting to breathe more and more and more quickly, which is one of the things that aspirin does. And when people start breathing more and more quickly, people start worrying about respiratory failure and intubation. And when you intubate a aspirin poisoned patient, they die because the acid builds up, which allows more the acid builds up, which allows more aspirin to diffuse out from the blood into the body, which causes more toxicity, and it just becomes a downward deadly spiral. And that happens pretty routinely, unfortunately, because aspirin's available over the counter and people know about it, and it's a way for people to off themselves. So that's probably one of my most dramatic cases where all of that undergraduate chemistry knowledge and that medical school preclinical 2 years kind of has a place. And so I like to share that story as, yeah, it's a pain in the neck, but it really is important downstream at some point.
Yeah. Why? Let me rephrase that. When, for all the future emergency medicine docs in here right now, what should be that tripwire for them to send off that salicylic acid test?
Yeah, so I think that the tripwire for me obviously is a little bit different, but In patients that have a decrement in their bicarb, if their bicarb is less than 20, and they're of an age where perhaps they're taking aspirin on a regular basis, or they're confused and you don't really have a clear explanation, or they have a chest x-ray that shows a lot of fluid in there, but the heart is normal sized. These are all kind of clues that aspirin might be involved. And I get calls very frequently from the ICU of the little old lady who's admitted for pneumonia, who's been on antibiotics and is not getting better. And it turns out that it's not pneumonia, it's aspirin poisoning, and that chest x-ray with fluid everywhere, and the confusion and the rapid heart rate and the low-grade temperature elevation has nothing to do with infection and everything to do with this substance that they took.
Wow. And is this accidental overdoses? I know you had said offing themselves. For someone to get this high of a aspirin level, is it pretty on purpose, for lack of a better word?
Yeah. So frequently it's on purpose, but not always for intent to harm self. This lady was taking her aspirin because her ankle hurts, and she was told, when your ankle hurts, take aspirin. And so she was taking more than she should have. One of the things that aspirin does is it makes the kidneys not work so well. And so her kidneys got boxed, and then she was taking more, and it just accumulated to the point where she had that seizure and the other things.
Wow.
Aspirin is also a very common way for people who really, really want to die to take, because of its availability and because of these effects. And so it's kind of both. Yes, it's intentional, but the intent is a little bit different. One is to treat symptoms, and one is to end one's life.
Yeah, very interesting. For anyone who has questions about this specific case, go ahead and ask them in the Q&A. A good question from Amy about the residency path to become an addiction medicine or toxicologist, toxicology specialist. Are those separate residencies, or are they kind of add-ons to residencies that you've already done?
Yeah, great question. So addiction medicine currently through 2025 will allow a practice pathway, meaning you're some other specialist that is seeing patients that have substance use disorders, and you're treating them, you're managing them. After 2025, it will be a separate fellowship. It's a 1-year approved fellowship that one completes after a primary specialty. And literally any specialty is allowed, because addiction medicine, people with substance use disorders, crosses all the spectrums. The vast majority of individuals will come to that through family practice and seeing patients in clinic or internal medicine. There's a lot of psychiatrists that are also involved with substance use disorder and that treatment. Toxicology is also a separate subspecialty. It's a fellowship that lasts for 2 years. The vast majority of toxicologists in the United States are emergency medicine trained, but you can also come to that through pediatrics or internal medicine. I know of someone who's primarily boarded in neurology, who then subsequently did a toxicology fellowship. I know of a psychiatrist who kind of did a similar thing. And so, the sky's the limit. Obviously, there's the easy way and kind of the common pathway, but that shouldn't preclude anybody who's interested in finding another way.
Yeah. So lots of paths, which is fun, right? There's no one way to do whatever you want in this world as a physician. So the sky's the limit, which is great.
Absolutely. And I want to throw out there that just because you start one residency doesn't mean you necessarily have to finish in that residency. And some of the best emergency physicians that I know started somewhere else and did a couple of years before kind of seeing the light and saying, this isn't really where I want to be,
Yeah.
and recalibrated and kind of shifted into something else. And so it's really important to recognize that things change and priorities change, and you can change residencies. Sometimes it's harder, but that doesn't mean that it's not impossible.
Yeah. Yeah. It's interesting. I think the PA world has a good system where PAs can kind of swap around. They get burnt out in one field and go to another. They get bored in one field, they go to another. And for their own sanity, mental health, passions, interests, they're allowed to chase whatever kind of suits them. Obviously, they have to go find a job and get training in that job. But it's interesting because I think ultimately that's good for patient care. I'd rather have someone who is maybe newer into the field, but is passionate about that field, than someone who's stuck in a field and potentially burnt out and not operating at their best level because of that.
I agree with that 100%. And that's kind of why I chose my practice the way that I did. When I start feeling a little burnt out with emergency medicine, I take call for tox. And so it's kind of a built-in check to be having my hands in a lot of different things, so that I never really feel like, oh, I'm just stuck doing this again. I certainly feel that at times, but then it's my call week and I go and do the tox piece and the addiction medicine with that. And it kind of reinvigorates me to go back to the trenches, as it were, in the emergency departments. Yeah. And vice versa. When I'm, getting kind of burnt out with the tox, I have the emergency medicine practice to kind of balance that out. And I think that's one of the challenges in medicine is there's a reason that MD or DO comes after your name. It doesn't become your name. And it's really easy to get burnt out when your identity and everything that you are is wrapped up in your job. And so I've got a lot of different jobs and my hands in a lot of different pots. And so it kind of maintains that balance for me.
Yeah. So Maya asked a good question about the job opportunities for toxicologists. Are we in need of a lot, or is the market saturated?
Yeah, that is a great question. And it's obviously a moving target. And there's a lot of flux in toxicology right now. Historically, toxicologists were associated with poison control centers or academic centers. And that's kind of been the primary model for a long time. That's kind of evolving, and nobody's really quite sure of what's going to become of that. There's a limited number of poison centers, and that's kind of a saturated market. But there are places where independent groups are starting to pop up and saying to hospitals, hey, we'll see the patient in person. The poison control center doesn't. And so the next 5 to 10 years will be very interesting to see how this all plays out. Additionally, poison centers are always under the knife for funding and budgetary constraints. It's a specialty that it's very difficult to prove its worth because it's kind of funny money and it's all intangible. There's a lot of money that's saved when someone calls a poison center and they're able to say, hey, you don't need to go to the emergency department. But that's really hard to quantify in the same way as other medical specialties or other priorities. I'm very, very fortunate in that my employer values what I do. I actually have a contract with the hospital system to provide this service. Other places, other academic institutions, there's kind of a buy down in the number of shifts that you work in the emergency department. So there's a lot of different models out there. And again, the sky's the limit in terms of what you can find or maybe what you're able and willing to go out there and do and get that contract with the hospital system.
Yeah. Abby wants to know, what is the most rewarding part of your job? And on the flip side, what's the most difficult part?
Yeah, so specifically as a toxicologist or as an emergency physician, and I can speak to both.
Yeah, let's get super nuanced.
Yeah, so I think my favorite part of my job, and it kind of overlaps because I'm seeing the same patients in both roles, is when patients recognize that, hey, maybe this life path that I've been on isn't really working so great for me. And they make the changes that are necessary to 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 fix some of those things. And nothing gives me more satisfaction than seeing a patient in the emergency department who perhaps I've seen multiple times for overdoses or complications associated with whatever it is that they're doing, who tell me, oh, I've been clean and sober for 6 months. Mm-hmm. And even talking about it right now, I get this huge warmth and glow. And I always commend them and say, that is absolutely awesome and fantastic. Let's make that 6 years. And they get a big smile. And I say, let's make that 16 years. Let's make that the rest of your life. And so that gives me a tremendous amount of satisfaction. But the flip side of that, and what is frustrating, is seeing people making the same poor decisions and choices over and over and over and over and over again. And so it's two sides of the same coin. I really see my job as keeping people alive long enough in that context to make a better decision the next time. And hopefully that decision is the one that will rid them of whatever it is that's getting in the way and causing them to harm themselves in the ways that they are.
Yeah. Do we have good data? I think the smoking cessation world, the data is like, it takes someone like a dozen times before trying to quit before they actually accomplish that. And in the more kind of harder drugs, is there any data that shows that there's that kind of stepwise multiple attempts and then they finally kind of get there?
Yeah, as a big kind of 30,000 foot overview, I think that the data is there that relapse rates are super high and it takes people multiple attempts. But what makes it so challenging is that every individual is so nuanced and their reasons for use or the circumstances that contribute to their use are so individualized. There's this great quote that I love citing, and it's that every treatment works for some patients, but no one treatment works for every patient. And I think that puts this in context that, it'd be really great to say one size fits all, but it doesn't. And the reasons that people have the disorders that they do or continue to use or the context that they use is so individualized and nuanced. And this is a disorder that crosses, the full biopsychosocial paradigm. And as physicians, we have a tendency to medicalize and think, oh, it's the American way. Just give them a pill. That'll fix everything. And it doesn't. And, sometimes people use because they're missing something in their life. And sometimes people use because there's been something in their life that has been traumatic or is a big issue. Again, these are big 30,000 foot, black and white kind of descriptions. But all of those issues have to be explored and teased out and nuanced in order for someone to find a place where that drug of abuse isn't the most important thing or isn't such a big component of their life.
Yeah. Something I don't think I learned in medical school, but much later, and actually through a podcast listening to actually California's Surgeon General, I think that's her title, is ACEs. Is that something, as an addiction medicine specialist, are you getting an ACE score with your patients? Is that something you're interested in, or is that something that happens kind of before they reach you?
Yeah, so that's a great question. That is definitely a blossoming and burgeoning field of inquiry.
Yep.
Generally, I
And
don't.
actually, let's pause for 1 second. Define. So ACEs is Adverse Childhood Event Score, and it's you go through a survey, and it's like, were you sexually abused as a kid? Did you have X, Y, and Z? And you add up the score, and there's some really strong correlations between obesity and addiction and all kinds of things.
Yeah, absolutely. I don't generally do that. And the reason being is that my role is more acute, stabilize, get people where they need to go to receive long-term treatment, whether that's medical treatment, psychological treatment, kind of a blending of the two. But this is a really interesting field. It's funny that you bring this up because a friend of mine just told me about a book called The Body Keeps the Score.
I'm reading it right now.
Yeah, I have it downloaded. I'm going to be reading it, when I get a little bit of time. And that is a huge component of people's experiences,
Yeah.
and how influential that can be. I love to bring up, it wasn't a adverse childhood event, but I deployed with the US Navy to Afghanistan, and I was stationed in the Afghan National Military Hospital as a physician mentor. And I went there as a fully trained emergency physician, having been, for lack of a better term, inoculated with trauma and stress and all the things that I did in emergency medicine. But there were members of my team who were administrators or non-medical hospital personnel, and they were very traumatized by the things that they were seeing and that they were involved with.
Yeah.
And I think as a general rule, again, big 30,000 foot overview, we as a society do not do a very good job of teaching people how to deal with stress and anxiety and these adverse things. We are a digital age, Facebook, social media, rainbows and unicorns. Everybody's life except for mine is wonderful.
Yep.
And that's not always the case. And so this speaks to some of these nuances and how complicated this topic becomes very, very, very quickly. The rabbit hole gets deep, and addiction, toxicology definitely taps into a lot of those issues.
Yeah.
I generally don't, because it's not germane to what I'm doing, but I do know that our local resources spend a lot of time discussing those issues with patients and teasing those out and addressing those.
Yeah. Since you brought it up, let's talk about that for a second, because the students listening to this are going to go through situations that are going to potentially lead to some stress, some anxiety, going through a pandemic and being potentially worried about going back into a workplace where you are knowingly exposing yourself to these viruses. Now monkeypox is now a virus of concern. Geez, can we get through one before we go to another? From all of your experiences, what is something that we can do as individuals in this profession that exposes us to a lot of trauma, other people's trauma that we have to go home with? What's your recommendation for how people can take care of themselves in these situations?
Yeah, that is a great question. And what I have found that works so well for me, and I'm certainly not perfect at it, and I still struggle with it, my job very much is one that allows me to leave it at work. And, for lack of a better term, I'm kind of a shift worker. I put my time in, and then I'm able to come home. I'm married. I have 6 children ranging in age from 3 to 14. And so that gives me so much delight and gives me such an out from thinking about work and thinking about the stressors at work. The other thing that gives me, that I have always had something that I do in addition to medicine, MD, DO does not become your name. I'm still Mike, whether I'm a doctor or not. And I think that's really important to maintain that identity separate from what we do or separate from what's going on in the world around us. Mm-hmm. I exercise every day, and I kind of focus on those basics. I try to get as much sleep as I can. I try to eat healthy. I try to exercise. And one thing that I find really, really helpful when I'm super stressed out or super anxious is something along the line of mindfulness meditation or yoga there's myriad different techniques out there, but there have been periods of time in my life where I was really anxious and panicky, and following some of those practices, mindfulness meditation, has helped dampen that and given me the perspective of what's most important. I also am involved in a religious organization that keeps my focus much bigger and broader than the immediacy of the mask and goggles that I'm wearing at work every single day, and reasonably can anticipate probably doing that for the rest of my career.
Yeah, that's amazing. Let's talk about the connection, obviously, with addiction medicine and mental health. How closely are you working with the mental health team, psychiatrists, psychologists, et cetera?
Yeah, so great question. I'm pretty good friends with a local analyst for the Department of Behavioral Health, which in my particular county is the one that runs the majority of the outpatient substance use treatment programs. There's a huge connection, and generally speaking, that connection is more outside of the hospital than it is in the hospital, but frequently those overlap as well. A lot of the patients that we see who overdose on substances, both drugs of abuse, but also their pharmaceutical, have substantial mental health challenges that are prompting these behaviors. And so pretty much all of the patients that I see who've acutely overdosed on something are going to be seen by a mental health provider and evaluated to start medications, change medications, get them placed in a psychiatric facility, or arrange outpatient psychiatric care. So there's a huge link there. And it's difficult to tease out what the direction of that association is. Does mental health challenges lead to substance use disorders or vice versa? And the answer is probably yes, all of the above. We know that long-term use of substances changes the physical structure of the brain chemistry, and then it becomes a chicken or egg problem. And it's sometimes difficult to tease out which is which and what started when. And so it's all treated together.
Yeah. One of my favorite topics to discuss is more policy related. I live in Colorado, where we were the first state to legalize marijuana. I think city of Denver, I don't think the whole state, city of Denver has decriminalized mushrooms. Oregon a couple of years ago decriminalized or voted to decriminalize all drugs. As an addiction medicine specialist, I've talked to a few, where do you stand in terms of decriminalizing drugs to remove stigma to potentially help patients not fear seeking help?
Yeah, and this is a super, super controversial topic, and it's a super complicated topic.
Yeah.
I tend to fall kind of along the libertarian bent when it comes to politics, which certainly is involved with this. I don't really care what you do as long as you take responsibility for it. And that's a really difficult place to be in as it relates to drug use and drug criminalization. And, it's always kind of been described that, marijuana is not a gateway drug. Well, the evidence suggests that it probably is. And there's a lot of genetics that are involved with substance use. There's studies that show that up to 50% of substance use disorder is genetic. And I just worry sometimes about the genetics and the play in the environment, where now there's a very, shall we say, laissez-faire environment where drugs are freely available, and someone who may have a predilection to is going to have issues simply because the environment is more conducive to that. On the flip side, decriminalization certainly may help with people seeking treatment, but it's uncharted waters, and there's no proof that that is in fact the case. There's a lot of social, additional social constructs and difficulties associated with that. Legalizing cannabis has huge issues as it relates to driving and driving under the influence. And there are lots of legal cases that surround that. And you could say the same thing about any of the additional substances that people use and abuse. So I don't know. I don't think that it's, I don't think that it's an easy issue. I don't think that it's a clear-cut issue. And there's pros and cons to both sides of the argument.
Yeah. Very, very political answer. I recommend everyone go explore what Portugal did back in the 90s. A very interesting case study in decriminalizing drugs that we don't know if it will translate to our society, to our culture. But it's always interesting. And I'm excited to see data come out of Oregon eventually. That may help us make those decisions for better, right? We work in an evidence-based fields, and it's good to make decisions based on evidence, which unfortunately as a society we don't always do. Right. Talk about the qualities. A good question here. Qualities that you think make someone to be a good addiction medicine specialist.
Yeah, so I think the qualities that stand out are the ability to be inquisitive and the ability to ask questions and to explore things, to kind of think outside of the box. I think it's also really important to recognize that what we learn in medical school and we learn in residency ultimately is going to be proven false. We just don't know when or how. And so the ability to kind of hold, for lack of a better term, two things in one's mind at the same time. We know that what we're doing now, 100 years from now, somebody's going to look back and say, what a bunch of boneheads. But also know that this is the best that we have right now. And we're going to pursue that because that's the best that we know. I think balancing being caring and compassionate without that compassion fatigue that we kind of talked about earlier, or having the mechanisms in place. The way I describe it is you're a grief sponge. And sometimes your sponge gets overfilled and you need a way to wring out the sponge. If you're someone who takes things personally or becomes emotionally overwhelmed by the rotten things that happen in people's lives, or kind of personalize that, then emergency medicine, tox, and addiction medicine might not be the right place for you. Because it is a field wrought with suffering and all that's wrong with being a human being and all the rotten things that can happen to people. But if you can be compassionate and provide good care and then let it go, then that's a recipe for success in the field.
Mm-hmm. Yeah, I love it. As our good friend Elsa says, let it go.
Right.
Tegan asked a good question in terms of the toxicology side of things. How often are you seeing heavy metal poisoning in your field? And are we seeing increases, decreases with unleaded fuel? It's interesting. I live right next to a general aviation airport, very busy one, and I was reading some stuff about lead contamination because general aviation still uses leaded fuel. And I'm like, I wonder if my town's ever looked into this as I'm swimming in the pool that planes fly directly over.
Yeah, that is a great question. I will confess that heavy metals are certainly a field, are part of toxicology, but they're a much hated part of toxicology. And there
Interesting.
are a handful of people out there in the United States that this is their thing and they're super interested in it and they know it backwards and forwards. My specialty is very acute, medically oriented. And so I don't see a lot of heavy metal poisoning because it's more of a chronic, indolent, long-term thing. I've seen probably 3 cases of lead poisoning that had more of an acute presentation in the last 11 years that I've done this. One was a kiddo that was eating paint and came in with severe abdominal pain, nausea, and vomiting. And we were able to treat him and improve his symptoms acutely and then kind of hand him off to his pediatrician to kind of manage more long term. And then the other 2 were related to retained bullets. One individual had been shot 25 years ago. The bullet migrated into a joint capsule. Joint fluid is very acidic. And so it was basically leaching lead from this bullet. And he came in with, wrist drop, ankle drop, and all of the symptoms associated therewith. Generally, heavy metal poisoning doesn't typically present that way. It presents more kind of weird symptoms over a long period of time that is going to go to a primary care doctor who may or may not think about it and may or may not send testing to try to make that diagnosis. I don't know the statistics. I don't know anything about lead in the environment or other environmental contaminants. The big thing right now is polyfluoridated compounds and firefighting foams and whatnot getting into the water supply. This is just part of living in a modern world where, for lack of a better term, better living through chemistry. Sometimes it's better living acutely until adverse events and adverse effects are discovered more long term, and then we develop methods to mitigate or to change that. But heavy metals, I'm familiar with them, but it's not part of my standard practice.
Yeah. Interesting. Very interesting. What's the harm? We'll just grow a second head and then we'll try to figure out what it was caused from. Oh, maybe we shouldn't have been using Teflon on all those pans forever. Oh,
Exactly.
well.
And it's also really difficult because we're still stuck with what do we know right now? And this is a huge policy question that the United States and other countries have struggled with. Currently, the way that drugs are approved, chemicals are approved in the United States is an absence of, I have to be really careful with the way that I say this, demonstration of an absence of harm, not proof of safety. And those two don't always mesh very well. What we know right now is that this is okay, but as more information becomes available, maybe it's not okay. And drugs get approved and people are using them and oh crud, there's all these adverse events. Now the drug is removed from the marketplace. And other environmental chemicals are the same way.
Yeah. Interesting. It's almost like they're proving a negative. Like,
right.
How do you do that? And it comes up a lot in food, as we just saw with the new lawsuit against Skittles, with this like titanium something or other that they use here in the States, but they don't use in Europe because that specific chemical is banned. So it's interesting.
Yeah, it is a very interesting world, and it's fraught with emotions and politics, and money plays into it in big ways. Drug companies will often lobby the FDA to change package inserts to list side effects on their competitors' products, and so there's all of this is at play. And there's not an easy answer, and it's not ever clear cut. And there's also studies that are ultimately debunked. DDT was used for a long time to kill mosquitoes, and it kind of fell out of favor after the release of a book called Silent Spring by Rachel Carson in the late 1960s, and there was concern that it was causing birds' eggs to weaken and that they were dying and things like that. So DDT, very few people use it anymore, even though it basically saved millions of lives as it relates to malaria. Well, there's new evidence that suggests that maybe it didn't do what Carson described, and maybe there was confounding variables and other issues at play. And so that's the other part of medicine, is we do the best we can, and it's a continual process of discovery and improvement. And what we do now, 20 years from now, will ultimately be proven to be false. And in my short time, I've been practicing emergency medicine since 2004. I've seen so many therapies that this is it, this is the answer. After a few years, no, we don't do that anymore.
Yep. Yeah, it happens. Broken bones, bed rest. Concussion, bed rest. It's like, no, it's the worst thing you could do. Go out there, move your body, do the things. So Dr. Mike Durock, thank you so much for coming on eShadowing, sharing your specialty with the few hundred people that are here today, hanging out and learning. Any final words of wisdom as we part ways?
No, I just want to say, goes to everyone who's interested in medicine. It is a wonderful career. I've loved the vast majority of what I have done. I just want to encourage people to recognize that it's a long road to hoe sometimes, and that's okay, and it is well worth it.
Nice. Well, I appreciate your time and sharing your wisdom. I hope everyone learned something. We'll see you again soon. Bye. Thanks, Dr. Durock.
Absolutely. Take care, all. Bye-bye.